as is fondly called. I will be with you within this period of time to discuss SGS 711, that is surgical evaluation, preparation, and instrumentation with respect to surgical patients. Now, going by looking at the surgical evaluation as it is very paramount for one to be able to satisfactorily perform surgical procedure in a given patient. And for one to be able to achieve that, there is need for a careful approach in the pre-operative and also post-operative preparation of the patient per se. What I mean here is that you need to evaluate the patient pre-operatively to take decision whether the surgery is necessary or there are some other things that one will be able to undertake before going into the surgery proper. Then so also perioperatively, as one is trying to perform the surgery, whatever it is that is needed, one has to also be well acquainted with, so that in cases of eventualities, one will be able to find his way of at least becoming success at the end of it all. And the reason why it is paramount to do this is for one to be able to anticipate the perioperative possible complications, as well as also the possible postoperative complications. So in a nutshell, the objective of this component is to understand the general principles of pre-operative preparations, and also to be able to appreciate the risk factors associated with some certain patients in order to reduce them before undertaking the proposed or the arranged surgical procedure, or during the surgical procedure, as well as also post the aftermath of the surgery that one that some of these may occur. Then so also there are some certain principles attached to some specific types of surgical procedures. So these are some of the reasons why one should be able to undertake this kind of surgical evaluation of the patients. Now, in general, for one to evaluate a patient, there are some certain things that should be able to guide a surgeon. And here we are talking about the complaint being brought by the client or the owner of the pet to you. So that complaint should be able to prompt you as to what information. What I mean here is the history you are to collect from the client. So the complaint should be your major guide, or the request, so to say. And having that in mind, then you will now go ahead and take relevant history with respect to the complaint or the request by the client. Then, as part of the relevant history one should take, you have to also consider the past medical history of the patient. Because your intervention, some people or some surgeons used to say that surgeons are next to God. It's only surgeon that will now go in, change some certain orientations and expect that the patient should come out and live his or her normal life the way it was before the intervention by the surgeon. Then so also one has to also take the history of previous medications apart from other medical conditions. Were there medications given before that presentation, or with respect to the previous medical condition or surgical conditions, were there treatment given and what were the responses? Then so also one has to check the vaccination history. All these are critical things one should be able to do And what we are trying to present here before everyone here, we are presenting an ideal situation. And you know, sometimes in a real situation, you may not be able to have the luxury of asking all these questions. Then, as part of the evaluation, after you have obtained the history, then you now go ahead with your clinical examination. And when we talk about clinical examination, as we all know, we are referring to the uh, checking the vital parameters of the patient as well as physical examination of the patient. And for the vital parameters, as we know, we normally check the temperature, which will usually tell us about some of the metabolic activities going on within the system, whether you're having an anabolic or catabolic process going on. And so also the pulse should be able to give us some insight as to the status of the cardiovascular system, and while the respiratory rate should be able to tell us information or give us information about the respiratory system. But one thing we should know, they they are all interrelated, because it's only when you need to burn some certain calories that oxygen will be needed. And the calories are usually being supplied by the blood. Here we are talking about the vascular system. So once oxygen is being added, that is the respiratory system, then you are bound to be able to burn that calorie for you to be able to know whether you're having a catabolic process that is yielding energy. Then apart from taking the general physical examination, then now you will now try to move to a relevant system of interest based on the client complaint. So here you will take your time and lay emphasis or pay more attention to the system in question or the system of interest as presented or complained to you or requested to you by the client. And so also as you are evaluating these systems clinically, you have to also be relating it with the prior uh, uh, history of such system that you were able to obtain. And if, for example, what you obtained regarding the system was a little bit shallow, so you may have to go back and be inquiring for more information regarding that system of interest. So having done that, and as part of your evaluation, you have done 2 or 3 basic components of it, then you may have to also move down to laboratory examination if you are able to establish some certain information that will guide you on the next step to go about. So in the lab examination, since it's a surgery, usually there are some routine examination that one is expected to do. And out of this, we have complete blood count. And in the course of blood count, it's very, very important for one to be able to also as well extend the hematologic evaluation down to the random blood sugar, and possibly serum creatinine. Because the reason why we go for the random blood sugar here, we want to establish whether you have a diabetic patient, because you know the way you are going to prepare the diabetic patient for a surgery will be different from when you have a patient that is apparently healthy. Likewise, you may have to also check the serum creatinine to be able to ascertain the renal clearance, whether you're having a patient with a renal problem. Then as part of the routine laboratory investigation, you can as well collect urine for other complete urinalysis. Can as well extend to go down to microscopic evaluation if you are able to find some certain abnormalities. Then optionally, you may as well take that of electrocardiography just to check the status of the heart. And also, sometimes you may have to uh, utilize diagnostic imaging, that is ultrasound scanning and probably radiography. It depends on what is before the surgeon at that time. And also, based on what the surgeon is able to classify the patient to be, as we shall see in due course. Then it is worthy to note in young and animals that are usually fit for minor surgeries. This kind of intensive investigations are not necessary. So having done this with a physical examination or clinical examination, the laboratory work, then now you have to you have to use what you have at hand and be able to see, assess the surgical risk of the patient before you. And there are two basic systems of scoring that are being used. But I know the one that we mostly use is the ASA system of classification. And there's also another one, which is the Apache system of classification. For the Apache system of classification, the Apache is an acronym of acute physiology and chronic health evaluation, while the ASA classification the ASA is an acronym of American Society of Anesthesiologists classification. Now, for the Apache, it usually assists you in classifying the patient or the subject to have either acute or chronic condition. And some of the indices one will look for while utilizing the Apache system, one is the temperature, the rectal temperature. Then the second one is the respiratory rate. Then the third one is the cardiovascular system, which entails you checking the heart rate, mean arterial blood pressure. Then also part of the respiratory system, alveolar arterial oxygen gradient, arterial blood pH. Then some certain electrolytes like sodium and potassium, serum sodium and serum potassium ions. Then so also serum creatinine, as we earlier mentioned, when it comes to issue of us accessing the function of the kidney. Then it is also paramount to be able to check for the total WBC count, that is white blood cells count. Then the last one under this system of scoring is the GCL system of scoring, that is Glasgow coma level scale. And usually in this Glasgow coma level scale, they are being used to be able to assess basically some of the special nervous system and the central nervous system. And in the special nervous system under this GCL score or GCL scale system is that you will first assess the eye, because there is a grade that you will give to each. For example, when you look at the eye and you try to stimulate the eye, you did not record any response, so you give it score 1. And if you try to elicit like a kind of pain and you realize the animal was responding by opening the eye just based on the pain you elicit, then you give score of 2. Then so also when you did not elicit any pain, you only talk and the animal was able to open to look at you, then you will give a score of 3. While the other one that will carry score of 4 is just when the animal spontaneously on its own without any stimulus was able to open the eyes to look at you. So there you will give score of 4. So the index, one of the index that you use under this GCL score is the eye. And as I earlier mentioned, you have 4 scores there. And the higher the score, the milder the condition. It means the animal is more alert. And the lower the score, the severer the condition. It means the animal is not alert, it's tending toward moribund. Then the other index that you check under this GCL score is the verbal or vocalization by the patient. And here you will try as much as you think as you can to stimulate the animal, either to see whether the animal is going to respond through the vocal means of communication. If you try to elicit pain and no response, just like in the eyes, you'll score it to be 1. Then so also, when the vocalization is somehow incomprehensible, you can't even pick whether the animal is either barking or is just showing some signs of pain. That is, there is no, you can't comprehend what the animal is trying to communicate to you. You can now have score of 2. Then where you are able to differentiate what the animal is communicating to you, but it has multiple communications. It may be communicating that maybe there is pain. Then another thing, it may be communicating like there is calling for an attention. Maybe there is an intruder into the environment. So that one is a kind of inappropriate uh, means of verbal communication. Then you can now score that one to be a 3. Then where you discover there is complete confusion in the way the animal respond. Maybe the animal will shout, will back, then all of a sudden it will grab some stationary objects. Then later on it will back. So there's a kind of confusion. So there you will score it to be 4. Then where you have an oriented vocalization. So that one is telling that yes, the animal is relatively in its correct senses. Then you can score that one to be 5. Then the other index that you will also use in scoring is the motor function. Here you will try to elicit some pain. When you after elicitation of pain and you realize there is no response, then you score it 0. Or maybe immediately after eliciting the pain, then you discover that the animal is extending a particular area of the body, then you score it to be 2. Where you discover that the animal is trying to flex that area that you are able to sensitize, so you score it to be 3. Then where you discover there is withdrawal as a result of your stimulus, so you score that one to be 4. Then so also where you discover the pain is being localized, even wherever you touch, that will be the area that will be able to, the animal will be able to show some signs of tenderness. You score that to be 5. Then where you discover even with the pain, you talk to the animal and the patient is able to obey your command. Say stop it. Maybe the animal is vocalized, say stop it, and the animal is able to obey, or is trying to kick with the limb. And when you say, will you stop? And the animal is able to stop, then you score that one to be 6. So having these 3 indices, with some of the parameters you will use in scoring each of these indices, then you can now be able to classify your patient as a patient that is in severe condition when the total GCL score is low. Low in the sense that anything from 8 downwards. While when you discover that what you have is there is great response by the patient, then you score it to be milder. Milder in the sense that your score should give you between 15 to 13. Then in between 13 to 8, that you consider it to be moderate. So this is how you can now score the patient before you think of what to do next. Then the ASA classification, as we are more familiar with, this one has to do with you classifying the animal into, the patient into 5 categories or classes, as we have in class 1, which we believe to be an apparently healthy patient with no any form of disease. And these are kind of the patients that are usually presented for neutering, for that is elective surgery in general. And some of them are being presented maybe for removal of a tumor that is not causing, that is benign tumor, which is not causing any harm to patients. Then the class 2 group of ASA patients are those with mild systemic diseases. And most of them are the ones that are usually presented with surgical complaint. For example, the patient that has a wound, which requires some level of repair. Okay? And maybe these are the patients that have fracture, say simple fracture. So we classify these ones to be the patients with mild systemic infection, systemic diseases. Then the class 3 patients are the ones with severe systemic diseases, and these are the patients that 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 can be easily, in fact, they can easily show clinical sign without you necessarily going to laboratory for any investigation. For example, you can see evidence of dehydration, you can see evidence of anemia, or evidence of fever without you necessarily going to the lab for confirmation. Then also, amongst these kind of patients, there are the patients with valvular insufficiency, or they are asthmatic in nature, or they have compensated nephritis. Then for those in class 4 are the patients with severe systemic diseases, which is a constant threat to the life. Typical of this, when you have animals with congested heart failure or renal failure, or the other type of animal with cerebrovascular accident that led due to serious trauma, and also in cases of uncontrolled diabetes. Then the last class under this American Society of Anesthesiologists classification are the moribund patients, which they are not expected to last for the next 124 hours. So after you have done this evaluation, you did all your evaluation up to this level of classification. You know, by this time around, you must have come up with your diagnosis. Then the next thing, don't be in a rush to go into the surgery. The next thing is for you now to seek the attention of your client and try to educate him. And what you should educate the client on, one of it is your diagnosis. Educate him about what you are able to diagnose. Then the second thing is educate him about the possible medical or therapeutic interventions, be it surgical or non-surgical. Try and explain to him. When there is non-surgical, begin with the non-surgical, and let him see the reason why you should go non-surgical, if the need be. And even if you are not going to go by the non-surgical approach, that is the conservative method, you need to also explain to him why you should revert back to the surgical approach. Then even in the surgical approach, it is paramount to explain to the client the various surgical procedures you can employ in order to achieve what the client is out for. Then by the time you are able to do that, then you concretize or finalize on what to do. Then try and explain the probable complications that may arise right from the pre-surgical preparation, that is in terms of the anesthesia, what may come up with respect to the patient, then peri-surgical situation, as well as also the post-surgical possible complications. It's very, very important one should explain this, because whatever you are doing, you are not only before the before the animal subject. You are handling both the client and the pet at the same time. So you have to put that at the back of your mind. Then after explaining that, you have to also explain to the client the hospital stay or otherwise of the post-surgical management, how long it will take you, and what you need to do after the surgical intervention. Let the client be in good picture of what you are going to do. Then the prognosis of your intervention. This is the condition, this is how I intend to do it based on his presentation, and aftermath of my intervention with the post-surgical evaluation, this is the prognosis. Let the client be in the full picture. At least with that one, you'll be able to solve the client's problem. So having done this, then the next thing, you now have to tell the client the cost implication, because the client needs to know what you intend to do on his pet. And in every stage, these are the activities that needs to be done. So you need to explain that to the client. Let him see through. Let the client see transparency in whatever you are going to do. Then you can now talk about the cost implication. So after that, then you will now go back to the patient now and look at the patient based on your own classification. Either you use the Apache classification or ASA. If you are able to ascertain whether you have a patient with acute condition or physiologic conditions or it's a chronic physiologic condition. So you need to stabilize the patient as the case may be. And in stabilizing the patient, it may involve one, the antibiotics, that is the use of antibiotics for a period of time if you are expecting to have some infectious condition, or maybe the condition of the patient may warrant infectious agents to opportunistically invade and cause a problem. Then the other aspect of the stabilization, you may also have to uh, think of fluid therapy, which is either you want to replace the fluid, you want to see maybe it's anemic and you want to give blood transfusion before you think of going into surgery. And you should always remember what you have there in the with respect to surgery. You are going in there with scalpel blade, and any incision you make, you are expected to see blood. If you don't see blood, by implication, provided is an organ that has vascular supply, by implication, after your incision without seeing any blood, is typically telling you that you are dealing or working on a cadaver. So you don't want to have that situation. You need to stabilize the patient before you do anything else. Then the other thing also that you should also take into consideration is an issue of having oxygen therapy if need be. So as the case may be. So all these are part of what one should do in preparing or making the patient to be fit for the intending surgical procedure. And as I earlier mentioned, it's only when you have the luxury to do this. There are some certain patients when they come, in fact, there and then you may not even think of going deep to check the history. You just go in and begin to see how you can rescue. Then having stabilized the patient, then there are some certain things one should be able to do in preparing the patient now for the surgery proper. One of it is dietary restriction. And in dietary restriction, one is expected in adults generally to restrict feed intake between 6 to 12 hours before the injection of anesthesia. And we should know the reason why we do that. One of the reasons you want to avoid MSs, which may subsequently lead to aspiration pneumonia. So then the other restriction that one should also observe, or not necessarily to observe, is the issue of the water. Water can be allowed to be given ad lib, depending on the kind of procedure one is envisaging to undertake. Then in cases of also large intestinal surgeries, for example, one should be able to restrict the diet at least 48 hours before the commencement. And sometimes not only that, one may have to go ahead with enema. Because sometimes, given that 48 hours might not be able to be sufficient to evacuate the intestinal lumen, more especially when one is going in for large intestinal surgery. So it's very paramount one to know what kind of procedure he or she is planning to undertake. Then it is worthy to note that any surgery that is going to be greater than 4 to 6 hours in young patients, this restriction of food might not be necessary because of the problem of hypoglycemia. And if you must do it, you must be able to provide source of glucose. And bearing in mind that some of these anesthetic agents, once you have glucose, the glucose may potentiate their activity, which may subsequently affect the patient adversely. So as part of the patient preparation, apart from the dietary restriction, one should also look at the excretions around. For example, the issue of defecation and urination, we should be able to ensure that before we undertake or induce anesthesia, the patient is allowed to defecate and urinate. Because remember, after some of the key signs that we'll notice in dogs and cats when they are fully anesthetized, is to check for our 7 reflexes, and out of which one is the relaxation of the anal sphincters. So you see, if you have impacted fecal mass, then it will now come and even interfere with what you want to achieve. Then another thing also, like I earlier mentioned, with this dietary restriction, enema may be necessary when one wants to undertake colonic surgeries. Then so also in cases of abdominal surgeries, the urinary bladder needs to be emptied. So it's either you manually compress the urinary bladder once you are able to access it, or before the accessing the abdominal cavity, or you can just catheterize depending on what is available for you and what you think is going to be much more easier, and also depending on where you are going to do your surgical, where you're going to carry your surgical activity. Then another part of patient preparation is the issue of skin or hair treatment before that. And usually the patients are given antiseptic bath a day prior to the surgery. You can give antiseptic bath in order to remove some dirt and debris on the body. And sometimes you may need to even incorporate some acaricide when you have a patient that has so much ticks and fleas on the body. Then after that, part of the treatment of the or given to the hair or the skin, you need to clip the hair around the proposed line of incision, and the clipping or shaving should be liberal. And this clipping, shaving, bathing, and other things are all done outside the operating room, and preferably 24 hours prior to the commencement of the surgery. And after that, you need to look at the area where you clip or where you shaved and scrub clean with soap and water before the day of the surgery, so that you will now relatively decontaminate the skin. Then having done that, you prepare the patient. Now what is left is for you to move the patient into the surgical or operating room, and you will position the patient appropriately depending on where you want to do your operation, or you want to carry out your procedure. They may be positioned either in dorsal, lateral, sternal, recumbent position, or they may be in a standing position. And most of what one should always bear as part of the preparation while you are placing these animals or this patient on the surgical table, ensure that the side you are going to work on is exposed to be the uppermost. That is where you are expected to expose, so that you'll have free access to the site. And also you need to anchor some of the extremities with either the surgical table or where you have provision for the anchorage. Then lastly, you have to also scrub or prepare the surgical site using the germicide as well as also draping. So in brief, this is just the consideration or evaluation one should undertake when it comes to issue of surgical evaluation of the patient, as well as also part of the client, because whatever you are doing, you need to think of the client. So I will just pause at this point before we go into the next part of the presentation, which is going to be the instrument preparation and instrumentation. I will pause here if there's any question or comments, then we'll take it before we go on. Although I'm given just an hour to make this presentation, it's already after an hour. So, hello.
Hello, sir.
Hello?
Hello.
Yes.
Hello. Yeah.
Okay.
Yes, we can hear you. Is it Ogoke Wilfred that is talking?
Ugoke Wilfred is here. You can see my face. Yeah.
Oh, okay, sir. You are welcome, doctor.
Thank you, sir.
So you have had, I think, my brief discussion, so to say. Do you have anything to ask or to add to it, or a comment?
I think it is well understood. This is the first class, and I will need to digest these things and ask questions when we go through it again. I also want to ask if I don't know if these things, materials, will be made available for us, as a reference, something to we still go back to at the end of the day.
I will try and do, and because actually I have the PowerPoint here. Most of my discussions is just off heart. So I hope you will bear with me. Maybe when you go through the material that I'm going to send you, you'll be able to add to it, because the whole essence here, remember, is not full of theory. Is the experience that matter most.
Okay.
I'm being too theoretical. So I try to be theoretical so that I will try to scratch what you left in the school. By the time we'll begin to look at the practical component of it, everybody will be able to appreciate it.
Okay, sir. Thank you, sir.
Then I can see TT. This is your name. Sorry for not being able to pronounce your name very well. Is it Tazukwe?
Yeah, Tezungwe.
Tezungwe.
Yes,
Tezungwe.
Okay, Tezungwe. Other name, sorry, sir.
Tuba.
Okay, Tezungwe. I believe you have, because I have friends.
Okay. I can barely hear you, but all the same, I want to thank you for taking out time to make sure that this lecture is held. I know you've gone through a lot of pain and all these network challenges. We appreciate your efforts, sir. And I still want to add to what Dr. Wilfred said. He said, what I want to add to what he said is the recordings of your lecture, if it can be sent so that we'll be able to listen to it again, then draw up questions so that in a subsequent class we can bring forward. Okay. And my question is, in the preoperative assessment of the patient, I was expecting that maybe I will have I don't know whether there's a classification of the surgical patient and the interventions for social class. These are the primary interventions that are needed, if there's anything of such.
Well, actually, I that per se, because I it to be a general, and what I presented here is more of ideal situation. And you see, most of what most of us try to hold on to is the ideal situation. That is why some of us usually find it a little bit difficult when they see cases to handle. Because I must have this, I must have that. But let me just share one little experience with you here. There was a time I went to one Ruga to treat a dog. And when I went there, I realized I needed to do some surgery. And part of my experience, I know that the surgeries of such type, you can't do them without having some potential infections. And you must have, if possible, have what you call the antiseptic. So I had to reconstitute or formulate my own antiseptic. And do you know what I use? I use detergent. So that one is more of the practical experience. But here, what you told you must get chlorhexidine, gluconate, all sort of things. No, it's not you. It's not under must for you to do before you even go into the surgery. You must rescue that patient at that material.
Yes, sir. Network.
The client. Then the client will be thinking, "Ah, is this man really a vet or he's trying to corner me to collect my money and other things like that?" There are some things that actually, even if you go through the book, you never see them. So that is something I think we need to passion out and be able to create room to share among ourselves. But for the purpose of saying in this situation, this is how you'll approach it, then we are going barely back to our usual theoretical class. I don't know whether I'm communicating.
Yes, you are, sir. Actually, hello, sir. This experience, this is the fellowship experience. That's what it's all
yes,
about, sir. Yes, sir.
yes. And one thing you should also remember is a diploma program, but the experience is what matters most. It's not more of a theoretical aspect, the practical aspect.
Exactly, sir. Exactly, sir.
So are there other questions?
Thank you very much, sir.
So I don't know, should we quit at this one because I'm given only an hour to take this class and it's more than an hour by now.
Okay, if
So
I don't know if what you have planned for the lecture, if you're through with it, you can end the lecture. But
actually, I'm not through, but I think since we have reached a particular point that we can just stop at this point. I'm thinking it's better we stop. Then the next class we will now look at the other component because it's just like we have 3 components per se. Now I'm done with partly one component.
okay, sir. Okay.
Yes, so please, I think they will share the audio with you, and you can your emails to me. I will now enrich the PowerPoint with some words, then I'll send to you so that you can be able to check before class.
Yes, sir. We'll just send our emails via the chat platform on the Teams. So you can just see that immediately.
How many people in this class?
Thank you, sir. Yes, I think we have like 3 persons. Myself, Wilfred, and Imab and Kazayev.
Okay, so no problem.
Thank you, sir.
Yes. Thank you very much, sir.
Happy weekend to everyone. And also sorry for taking much of your time.
No problem, sir.
Good evening, Likita. Sannu mun gode, sir.
Dr. Mabel.
Sannu, sir.
How are you and enjoyment? How is Jos?
Fine, thank you, sir. Yeah, Ibada, sir.
So we thank God for everything. At least we are moving gradually.
Oh, Israel, Ibada, Iko.
Is it proper for me to digress?
No, this one is greeting. Share the class is almost over now.
The class is over, so
I've been quiet since
No
now.
problem.
It's just greeting you, sir.
Why did you
No problem. Digression is okay, sir. It's okay.
Huh?
The digression is okay. It's okay. It's
okay, maybe
you
let's just move into the small
go
practice to have. Yes, I just want to share a little bit experience with her regarding one case that she's fully aware of.
Okay.
Yes, Dr. Emmanuel.
Yes, sir.
Yes, you remember Friday?
Yes, sir.
Yes, I don't know whether he called you back regarding his dog.
Okay, no.
Because he called my attention, I went there and after checking the dog, I realized what was shown clinically is more of flea allergic dermatitis and
Yes.
some piece of if I that there are more of dermatophytosis, not microspores, dermatophytosis specifically.
Okay.
So when he also showed me the prescription you gave, I just slightly modify it, and at the same time I asked him to 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 communicate with you. But since then, I think he called me twice. He said that the condition is actually
Okay.
subsiding.
Okay.
So I think it's better you can contact him, let him send the picture of the dog to you so that you
Okay.
can see so far. Because
Okay. Thank you.
we had to fumigate the house at some intervals. Then we maintain that the ivermectin regimen you gave. Then
Yes.
so also I prednisolone.
Yeah.
Then with some other husbandry changes actually.
Okay.
So it's better you call him so that he will tell you the improvements.
Okay. Actually, he didn't update me. Maybe probably because we lost someone. So maybe that was why he didn't get back to me. But he actually told me that the dog was actually getting better. So I'll do as you have said. I'll do as you have suggested, sir.
I know there you deal with them a lot. And looking
Yes.
at the nature weather of Jos. I don't know whether you know that is my own hometown.
Just
Yes, my grandmom is there.
okay.
And I
Which
come to
area,
greet
sir?
around that, yes, around Terminus.
Okay. Yeah, I didn't know.
But I think there was a time I even called Abazi. He came and greeted my auntie there at Angulujos.
Okay, yeah, I didn't know.
In fact, I have my relations, plenty of them there.
Yeah. You see, I didn't know. Yeah.
My point of insight is Zaria, my action is Zaria, but origin is part of Jos, part of Bauchi, part of Kano. In fact, I'm polyvalent individual. Or in fact, I can say I am just hybrid.
True definition of a Nigerian. Sanusa.
So next time when I come, I will try and look for you because the last time I came was January. I was with Ababa throughout. In
Oh my
fact,
God.
I even lodged at his place.
Uh-uh. That's serious. Yeah, that would be nice, sir.
I hope you are enjoying that job because I know you have plenty cases.
Yes,
Except
we
that
thank God.
the time is what is dealing with you.
Yeah, it's true. It's true.
You should liaise and see how you can publish your cases.
Yeah,
Because
you're
I
right.
know I've been sharp on Abazi and Ababa regarding that.
But we lost.
By the time they
Yes,
come
we've
back,
mm,
by the time they come back, they are tired. I say, no matter what, even if it is one sentence, write and drop. Tomorrow you look for it, just open it and begin to do some certain things actually.
yes,
You
that's
can't
true,
just
sir.
system and you are not benefiting. Because when the time for what do you call it, promotion comes and you are not having sufficient papers, they will just say you are not serious.
Yes, that's
Nobody
true.
will hard work.
Yeah, true. That's right, sir.
This kind of clinical cases that you'll be having, they are the ones that will assist you.
Yes, you're right, sir.
So, sorry, my other fellows. I hope you are trying to publish what you have been doing.
Yes, of course, of course, and it's nice getting some of these advice from a distant senior colleague.
Maybe when we get additional time, we'll discuss at length the way we can also go about publishing this our I can say innovations because time here we are publishing these innovations, some surgeries on chicken, some of the even wound management modalities we are able to come up with. Maybe we'll begin
Oh,
to share I know I have some that are published and they are online. But it's better we try to encourage one another.
Yes.
Because knowledge, when you publish it, people will be able to see it and use it. Then from there, they will also see another opening for them to.
Okay. Thank you, sir.
But thank you very much. I wish us all happy weekend.
Same to you, sir.
Thank you.
Thank
Have
you
a
very
blessed
much,
day.
sir.
Thank you, sir.
Have a nice day. Thank you, sir. Yes, sir.